Dr. Charles Goh is the Chief Medical Informatics Officer from Singapore General Hospital. And he is a senior consultant at Singapore General Hospital in the Department of Nuclear Medicine and Molecular Imaging. He's a visiting consultant at Tan Tock Seng Hospital, Department of Diagnostic Imaging, and he is the president of Singapore Radiological Society.
I'm going to be talking about FAPI PET for GI and HPB malignancies. So first of all, what is FAPI PET? I think for some of you who aren't so familiar, I'll try to explain what's FAPI PET imaging, how can it be used for imaging GI and hepatobiliary malignancies, and what are some of the limitations and pitfalls of this imaging modality. So first of all, what is FAPI PET? So FAPI PET stands for Fibroblast Activation Protein Inhibitor PET. And essentially, what is the target? We are targeting fibroblast activation protein alpha, which is found on the cell surface of activated fibroblasts. So fibroblasts meaning any sort of fibrotic reaction that is active, but importantly for malignancy, also on cancer-associated fibroblasts. And these actually exist in the stroma around many epithelial tumors, but they are actually low or absent in normal human adult tissue except the uterus. And even for regular fibroblasts that are not active, meaning that there's no ongoing fibrosis, actually they are not really expressing FAP or fibroblast activation protein. So what are ideal targets that can be used to image with FAPI? Those tumors that have very high desmoplastic reaction, so a lot of very strong fibrotic reaction, and those who have high FAP expression in the stroma around the tumors. This is a relatively new imaging modality. I think it's only been in use since 2018, and that was the first in-human study out of a center in Heidelberg in Germany. But in the 8 years since, especially since 2023 onwards, we are seeing increasing clinical utilization. And previously, when I spoke to some of my colleagues from India and China, I understand that it's actually quite popular in India and in China right now. They're doing quite a lot of this FAPI PET imaging. So exactly what does it look like? Essentially, around the tumor cells, not in the tumor cells themselves, there are activated fibroblasts, cancer-associated fibroblasts, and we can target these using FAPI, which is a FAP inhibitor, with a tagged radioisotope, which a lot of times nowadays is gallium-68. So once the isotope goes to these fibroblasts, we can image it using PET imaging. And so why all this interest in FAPI PET recently? So once they first were able to synthesize FAPI in 2018, the center in Heidelberg actually went to test it with a whole range of malignancies, and they discovered that actually quite a lot of malignancies show a lot of uptake on FAPI PET imaging. So things like sarcoma, esophageal cancer, breast cancer, they actually demonstrated 28 different tumor entities showing quite a lot of uptake with FAPI PET. But then the next question is, we have FDG, so why would we need FAPI PET? And so when they did further investigations, this same group in Heidelberg, they looked at tumors where they have relatively low FDG uptake and actually conversely have quite high FAPI uptake. So in their further studies, they discovered, especially for pancreatic cancer, esophageal cancer, lung cancer, tumors of the head and neck, and the colon, we actually saw very good imaging characteristics with FAPI versus FDG. And in some of these cases, it's because the normal tissue that has uptake, for example, in the head and neck region, where all around your salivary glands and in your oral cavity, you actually have quite a lot of FDG uptake that can be normal. We don't see that with FAPI. And so in these types of cancers, it was thought that FAPI might provide more benefit compared to FDG PET. And so this was an article that they published in Radiology, actually showing different tumor types that actually show more uptake, similar uptake, or actually less uptake than FDG. And out of these, in particular for the lung, for breast, gastric, and pancreatic, as well as various other GI malignancies, it was demonstrated that there is actually more uptake on FAPI PET compared to FDG. And so FAPI might be useful instead of FDG in these patients. I think I sort of mentioned this in brief earlier, but also the difference in terms of background uptake is quite significant when we're imaging the abdomen. So on the left, we see FDG in this patient who has taken metformin, and I know that maybe not all of you are that familiar with looking at it, but in patients who take metformin, there can be a lot of uptake along the bowel. And in fact, even if you're not taking metformin, there's actually normal uptake along the bowel, which can be confusing if you're looking for serosal deposit or peritoneal disease. Furthermore, if you look at the liver in this patient, there's also mild uptake here on FDG, whereas the patient on the right, image using FAPI, you can see that the bowel actually does not have uptake, and the liver actually shows very minimal or negligible uptake. And so the peritoneal disease in the patient on the right can be very well imaged. So what are some of the oncologic applications of FAPI PET that we've been seeing recently? So a number of tumors that show low uptake on FDG, for example, this patient with an intrahepatic cholangiocarcinoma, imaged with FDG, and you see there's no increased uptake in the region of the cholangiocarcinoma. Whereas with FAPI, you can see the background liver shows very low uptake, but the tumor itself actually shows increased uptake compared to background. Or hepatocellular carcinoma, a tumor that is notoriously low in uptake on FDG. This too has shown promise using FAPI PET imaging. Here you see the patient here. On the left side image, there is increased uptake in the HCC and relatively low uptake in the liver, whereas this same lesion does not show increased uptake on FDG PET. Pancreatic cancer as well, as I mentioned, can show increased uptake on FAPI versus on FDG. So this one is a little bit tricky because we know that pancreatic adenocarcinomas can show increased uptake on FDG. So it's not in all cases where it's low, but we do know that it has quite highly variable FDG uptake. So there are patients who don't show very much uptake using FDG. In this patient, the tumor in the pancreatic head is well seen, but you will also notice that on the FAPI PET images, there's uptake along the pancreas, here indicated by the purple arrows, and that's actually likely due to pancreatitis rather than tumor. So beyond just showing you images, I think there have been increasing studies demonstrating higher sensitivity in larger groups of patients. So for example, in this study that was also again published in Radiology by a group out of China, they demonstrated that looking at FAPI PET versus FDG in tumors of the gastric, duodenal, and colorectal regions actually showed much higher sensitivity on FAPI PET for the primary tumor, 100% versus 53%, lymph node involvement, about 80% versus 50%, and even in distant metastases, so about 90% versus 60%. So definitely better performance in these groups of tumors compared to in FDG. And I don't want to show you that many studies. I also know that today we don't have that much time. So I summarized actually a number of studies that demonstrated that FAPI PET shows higher sensitivity in picking up primary lymph node as well as distant metastases in gastric, duodenal, colorectal, in HCC, and in the biliary tract. In pancreatic, there was a trend to it, but it actually didn't show significance. One thing to note, a lot of these studies, they tend to be small, and especially for these two meta-analyses, even though they have more patients, it was noted that bias may be an issue. A lot of these patients were actually imaged after FDG when the FDG PET was actually inconclusive. So you might understand why that may predispose to bias, showing that FAPI is actually outperforming FDG in these patients. So beyond increased sensitivity, I think the next question is it actually causing any difference in terms of clinical management? And there are early signs that this is so. So this is a study also by the group that was published in Diagnostics, looking at patients who are being treated with chemo-radiotherapy for pancreatic cancer. And they looked at FAPI PET imaging both at staging as well as restaging after treatment. So in these 27 patients, they were actually imaged multiple time points every 3 months after the chemotherapy until there was progression. And what did they find with this study? They found that at the point of staging, actually there was a very big difference in terms of treatment between just looking at CT images as compared to what information was available with FAPI. So at baseline staging, there was a major treatment change in terms of either the radiotherapy volume, in terms of the systemic therapy, in 52% of patients. And at follow-up, actually, 46% of patients had major treatment changes on the basis of FAPI PET findings versus CT. And I think the last major area I want to talk about today is actually FAPI PET in peritoneal disease. This is one area that has been a lot of interest, especially in my institution, and a lot of the surgeons are actually quite excited about doing this because in peritoneal disease, and I know that for all of us as imagers, small volume peritoneal disease can be very tricky. But for deposits less than 5 millimeters, we know that CT is not very sensitive, and even diffusion-weighted MRI can sometimes not show up these small deposits. FDG and diffusion-weighted MRI are probably the imaging modalities that have the highest sensitivity before FAPI PET for picking up this disease. But we have seen in many cases, both in the literature as well as in our own personal experience, that FAPI PET can be extremely sensitive for picking up occult peritoneal disease. And so these are two patterns of peritoneal disease that we typically see, either a very diffuse carcinomatosis or more nodular kind of variety of peritoneal deposits, and both of these are fairly well imaged with FAPI PET. So this is a case whereby it actually has omental caking already. There's very diffuse disease, but if you look at the FDG PET, if you look at the MIP images, as well as even in the axial images, you will see that there's actually very little increased uptake along the areas of peritoneal disease. And for those parts where it's on the bowel, it can be very tricky because with this kind of low level of uptake, you might assume that it's actually just normal bowel uptake. Whereas the FAPI PET in this case very clearly shows very extensive peritoneal disease in this patient. So in our institution, I'm not sure whether you do it for your reporting. For peritoneal disease, we've been working with our clinicians and they have tried to ask us to come up with a peritoneal cancer index scoring on imaging before they go in for laparoscopy. So for this patient, when they scored it using FAPI PET, the PCI score is 27 versus 9 only for FDG. We can see that the lesions are very much more pronounced, very much more obvious on FAPI PET versus FDG PET. So there have been some meta-analyses already published looking specifically at peritoneal disease. And in this meta-analysis with about 11 studies at 340 patients, out of which majority, about 2/3, had primary gastric cancer and another 40% had cancer of other types, it was shown that versus FDG, the FAPI PET was much more sensitive for picking up peritoneal disease, almost 98%, where the standard of comparison actually was operation of laparoscopy versus 50% for FDG on a per patient sort of basis. The comparison is a bit closer for other types of cancers, but actually still shows outperformance of FAPI with almost 98% versus 71% in FDG. And at both patient-based and lesion-based, in particular, if you look at the lesion-based, you had about 100% pickup for FAPI versus 27% for FDG. And I think that's actually the real key. I think FDG or other imaging modalities often underestimate. So at a patient basis, you might say, okay, this patient has peritoneal disease, but the extent-wise is going to be underestimated sometimes with conventional imaging techniques or even FDG. This is another paper also again showing higher sensitivity across multiple cancers. And here, the picture tells a thousand words. You can see that on the FDG images on top, the sites of disease not very obvious or very difficult to see, whereas on FAPI, these lesions actually showed up really, really well across a whole range of different tumor types. This is a case from our own institution whereby our FDG PET done in February of last year actually only showed the primary tumor along the gastric CA, which actually showed quite mild uptake. Whereas if you see on FAPI, the primary tumor shows very marked uptake on the green arrow, and the peritoneal disease, which was not seen on FDG, actually is very well demonstrated. This patient also received chemotherapy from March to July, and when it was re-imaged, you can actually see the response very, very clearly in terms of the burden of disease decrease in this patient. So that's something that our surgeons are very interested in looking at as well. Another thing that's quite helpful is, as I mentioned, just because there is fibroblasts there, they actually don't show uptake unless they're active, unless they're activated. So this has been quite helpful in troubleshooting some cases where there are some non-specific peritoneal nodules seen in some patients. We're not sure why, but when we have imaged them with FAPI PET, if they don't show any uptake at all, I think we become much more confident about saying that these are less likely or unlikely to be peritoneal disease. In this patient, laparoscopy actually confirmed that these tiny nodules in the abdomen were not peritoneal disease. So finally, just some limitations and pitfalls. I've talked a lot about the advantages of FAPI PET, but we also know that because fibrotic reactions actually happen in a range of different conditions, these can show false positive uptake and be mimickers of tumor. So degenerative conditions, scarring, wound healing, or other kinds of fibrosis actually will show increased uptake. And in this paper in the Journal of Nuclear Medicine, it showed that 81% of patients who were imaged with FAPI had some other site of non-specific uptake. So we have to be very, very careful before we overcall disease in patients. Things like pancreatitis, or cholangitis, or IgG4 disease all show increased uptake. Degenerative conditions, just like FDG, can show increased uptake. And this is one area that has been quite problematic for us in our own clinical practice, scarring or wound healing. So post-treatment, so post-surgery, sometimes insertion of certain tubes around the tubes, we see a lot of non-specific uptake on FAPI PET. Again, any kind of inflammation, thyroiditis or periodontitis, etc., or even infective diseases like tuberculosis can show quite a lot of uptake. So I think I'm finishing in good time. One of the things that we have learned is that we can't always take things at face value. A lot of the papers that have come out recently, they are quite small, a lot of them retrospective. We're still waiting for more good quality data. In our clinical practice, there are some particular conditions that have shown really good performance with FAPI PET. So in particular, peritoneal disease, for troubleshooting in our pancreatic cancers as well as our GI malignancies, it's been very, very useful for us. So we would recommend FAPI PET in tumors with very strong fibrotic reaction, known to have low FDG uptake, or in areas like around the bowel, maybe around the brain, or in areas around the oral cavity where there is high FDG uptake, quite useful. In our institution, it's approved by our sort of board for use in pancreatic, gastric, and peritoneal cancers. And finally, I just show you some of the limitations, some of the non-specific uptake can happen in FAPI. So I thank you for your time.